The nose is even more interesting on the inside than it appears from the outside. The skin of the nose is supported by a skeleton made up partly of bone and partially of cartilage. The upper part of the nose is given its shape by two nasal bones which attach to extensions from the maxilla, the bone that forms the front of the face, between the eyes and the mouth. A bony divider called the septum separates the two halves of the nose in the middle and attaches to the floor of the nose, which is also the roof of the mouth, the hard palate. The lower half of the nose is made up of intricate cartilages responsible for its complete and individualized shape. There is also a cartilaginous septum that joins the bony septum and separates the two sides of the nose in front. Each side of the nose is divided into compartments by mucosa-covered, seashell-shaped bony structures called turbinates. These structures are responsible for warming, humidifying, and filtering the air we breathe so that 10 degrees Fahrenheit environmental air is close to 98.6 degrees by the time it enters the lungs. The nose receives blood from arteries that originate from the internal carotid arteries, which supplies blood to most of the face, and the external carotid arteries, which provide blood to the brain. Toward the front of the nasal septum, several of these vessels come together. This region is called Kieselbach's plexus, an area that is the most common source of nosebleeds. The interesting anatomy of the nose predicts the types of problems that commonly afflict it. Bleeding or epistaxis is certainly one of them, and although it can be frightening, it is usually controlled easily. Most common nosebleeds originate toward the front of the nasal septum in the region of Kieselbach's plexus. They are often caused by trauma, usually from a fingernail or a foreign body, especially in children. But other factors can predispose people to nosebleeds. Those include very dry air, often produced by forced air heat, air conditioning, or air travel, health problems, and medications that affect blood clotting, including aspirin. Nosebleeds near the front of the nose and not associated with medical or drug-related problems often can be controlled easily with direct pressure. The thumb and forefinger should be placed against the entire bottom half of the nose, and firm pressure should be used to compress the fleshy sides of the nose firmly against the septum continuously for 10 minutes. If done properly, this maneuver is quite uncomfortable, and it takes a lot of discipline to wait out the whole time. Once the bleeding stops, the person should refrain from nose blowing for at least 24 hours. If this first aid measure does not make the bleeding cease, or if nosebleeds occur repeatedly, consultation with a physician, preferably an ear, nose, and throat specialist, should be obtained. More serious problems can also cause nosebleeds, including various growths, some benign and some malignant. Nosebleeds may also originate from the back of the nose. These are called posterior epistaxis and are apt to be associated with more significant blood loss. They may also be associated with other medical problems, including hypertension, high blood pressure. This type of bleeding usually requires medical treatment, sometimes even packing or surgery. Cautery or packing may also be necessary for severe persistent nasal hemorrhages from the front portion of the nose. Nasal obstruction is another common problem that results in difficulty breathing through one or both sides of the nose. Many things can cause this. The common term, deviated septum, means that the cartilaginous or bony septum, or both, isn't a straight partition in the middle of the nose as it should be. Rather, it may be displaced off to one side, or it may protrude into different levels of the nose on one or both sides. When a deviated nasal septum causes symptoms, it can be fixed surgically, usually under local anesthesia. An area called the nasal valve near the upper inside front part of the nose is particularly important for airflow. If this region is compromised even just a bit, breathing becomes very difficult. This can be demonstrated by gently squeezing the nose about 1/2 inch back from the tip and about 1/2 inch down from the dorsum, straight portion of the nose. The nose may also be obstructed by allergy, which causes the linings of the nose to swell, obstructing the spaces designed for airflow. Nasal fracture is another common problem. The nose is an easy target during fights and often gets in the way of baseball bats, elbows on basketball courts, soccer balls, hockey pucks, and other animate and inanimate objects. Most broken bones can be set easily with local anesthesia if they are examined promptly. To get optimal results in certain fractures, surgery may be required. This can be done immediately, but more often it is postponed for at least a few weeks until the bones are solid enough to permit readjustment in the operating room. Nasal fractures can be more serious. The top of the nose is the floor of the brain. If a blow is severe enough and angled in just the right direction, the nose can fracture through into the brain, resulting in serious brain contusion or hemorrhage, but more often in leakage of a clear, watery discharge from the nose. This is cerebrospinal fluid, CSF, the substance that surrounds the brain and spinal cord. A CSF leak is a potentially serious problem and requires prompt medical evaluation and treatment. Unfortunately, the nose is usually bleeding at the same time, and sometimes it's hard to recognize the cerebrospinal fluid leak until after the bleeding has stopped. However, persistent, clear, watery discharge from the nose or into the throat with a sweet or salty taste following nasal trauma requires prompt evaluation and treatment. Various growths can also arise in the nose. Benign polyps associated with allergies and sometimes with asthma can form. In some cases, they shrink in response to medications, but sometimes they require surgical removal. Other types of benign growths, as well as cancerous tumors, can make it difficult to breathe, and surgical treatment is very successful in opening a nasal airway. Not all growths that obstruct nasal breathing occur in the nose itself. The nasopharynx is the area of the throat behind the nose and the very back portion of the roof of the mouth above the soft palate. That is where the adenoids and lymphoid tissue are located. They commonly cause nasal obstruction in children, but this usually regresses and is not troublesome in adults. Nasal obstruction leads to mouth breathing, dental problems, snoring, rhinorrhea, and often ear problems. There are also more serious growths that can occur in the back of the throat in which obstructed nasal breathing is the initial symptom. Infections also may impair breathing. These are usually obvious because of a foul smell or taste or nasal discharge that is green, yellow, or brown in color. These require treatment by a doctor and often a laboratory culture for diagnosis and antibiotics. Other infections of the nose may not cause nasal obstruction. For example, an infected hair follicle near the end of the nose. These are common in people who pick their noses. These infections are really based in the follicles of the hair and can be much more serious than they may appear. The triangular region surrounding the nose is called the danger zone, even in medical textbooks. Draining in the angular vein, blood from this area goes straight from the nose into the brain, without first being purified by passing through the heart and lungs. People pick at infected areas in the nose because the sores are very uncomfortable, but can lead to serious, even life-threatening infection in the cavernous sinus, which is a major blood-containing structure inside the head. Infected hair follicles in this area should not be taken lightly, and treatment with antibiotics, warm soaks, and strict avoidance of manipulation is critical. It's best to choose an antibiotic that is effective against staphylococcal infections. Among other things, the nose is used to help us smell and taste. Taste and smell disorders are not discussed at length, but it's worth mentioning that loss of the ability to smell should not be ignored. Sometimes it's easily correctable. However, it may be the first warning sign of a potentially serious medical problem that requires complete evaluation and treatment. The nose is intimately related to the paranasal sinuses. The sinuses are air spaces in the bones of and around the face. Most so-called sinus problems, as popularized in television commercials, are actually allergies or inhalant sensitivities. However, sinus infection does occur and usually is associated with persistent infected discharge from the nose, facial pain, and occasionally headache over the eyebrows. However, headache is caused by sinus problems much less often than most people think. Rhinosinusitis is one of the most common medical complaints, with an estimated 33 million Americans making up to 25 million office visits annually for symptoms associated with the nose and paranasal sinuses. Professional voice users, such as singers, actors, and teachers, are especially sensitive to alterations in the normal physiology of the upper respiratory tract, and rhinosinusitis can lead to maladaptive technical alterations in minor cases and can cause disruption in professional performance schedules when symptoms are more severe. Chronic symptoms and complications of rhinosinusitis can even threaten a professional voice user's career, although for most patients they are not disabling. They are also particularly troublesome for chefs and other professionals who depend on an acute sense of taste and smell, which may be impaired by nasal obstruction or pathology, including damage to the olfactory nerve and related structures. Advances in the understanding of the pathophysiology of rhinosinusitis have improved both medical and surgical therapy, and most patients can expect significant relief from their symptoms with appropriate treatment. The paranasal sinuses are paired mucosally lined spaces in the facial skull that are named for the bones in which they are found. The maxillary, cheek, ethmoid, between the eyes, frontal, forehead, and sphenoid, center of skull, sinuses are anatomically distinct but functionally interrelated. The mucosal lining of the paranasal sinuses produces several liters of mucus each day that must be transported by ciliary, moving hair-like structures, activity of the mucous membranes, out of the sinuses and into the nasal cavity, where it is swept posteriorly and swallowed constantly. This mucociliary blanket traps inspired particles, bacteria, and viruses, and clears them from the nose, constantly filtering and humidifying inspired air. Mouth breathing bypasses this important conditioning step, leading to drying of pharyngeal and tracheal secretions, increased inspiration of pollutants, and loss of nasal resistance. In patients with reactive airways, such as asthmatics, increased particulate contamination of the lower airways can trigger bronchospastic reactions, worsening asthma. There is a well-characterized association between the presence of asthma and sinusitis, and acute sinusitis is often associated with an exacerbation of asthma symptoms. Sinusitis is a result of impairments in the normal physiology and defensive systems of the nose and paranasal sinuses. The final common pathway resulting in sinusitis seems to be inflammation, leading to impairment of mucociliary transport, occlusion of sinus ostia, and bacterial contamination and overgrowth of the paranasal sinuses. For acute bacterial sinusitis, the most common inciting inflammatory event is a viral upper respiratory infection, URI. Viral URIs have been documented to cause ciliary damage, mucosal edema, and result in sinus opacification that often lasts for several weeks after the acute illness. Chronic nasal irritants also have been shown to increase the incidence of sinusitis. Airborne pollution, exposure to tobacco smoke, and other inhaled drugs all result in inflammation and impairments in normal mucociliary clearance. Inherited diseases and variants also can predispose a patient to rhinosinusitis. In cystic fibrosis, CF, abnormal chloride transport causes thick, viscous mucus that slows normal mucociliary transport. Some patients have an extremely mild impairment in chloride transport, and chronic sinusitis may be their only symptom. Similarly, defects in ciliary morphology and function are heterogeneous, and chronic sinusitis may be the most prominent symptom. Any disorder of the immune system can contribute to sinusitis. Immune deficiencies decrease the patient's ability to destroy bacteria when they have penetrated into the paranasal sinuses, leading to frequent episodes of acute sinusitis. Atopy, allergy, and other excessive responses of the immune system cause inflammatory reactions that can lead to sinus blockage and infection. Finally, many mechanical factors can predispose a patient to sinusitis. Chronic nasal polyposis can cause mechanical obstruction of sinus ostia and induce chronic sinusitis. Similarly, anatomic variations in the normal sinus drainage patterns may predispose an otherwise normal patient to recurrent sinusitis. In short, multiple factors contribute to and cause sinusitis through complex and poorly understood interactions. The Task Force on Rhinosinusitis of the American Academy of Otolaryngology, Head and Neck Surgery, has developed working definitions for the diagnosis of rhinosinusitis. It should be emphasized that sinusitis is a clinical diagnosis based on typical signs and symptoms, and that radiologic imaging and nasal endoscopy are not required. The major symptoms of rhinosinusitis include facial pain or pressure, facial congestion or blockage, nasal obstruction or blockage, discolored nasal or postnasal discharge, hyposmia or anosmia, purulence in nasal cavity on examination, and fever, acute sinusitis only. The minor factors include headache, fatigue, halitosis, ear pain, pressure or fullness, dental pain, cough, and fever. Patients with two or more major factors, one major factor and two minor factors, or purulence, pus, on nasal examination are considered to have rhinosinusitis. This diagnosis is further subdivided according to the duration of symptoms into acute, subacute, and chronic. Recurrent acute sinusitis is defined as more than 4 distinct episodes of acute sinusitis in 1 year. An acute exacerbation of chronic sinusitis is defined as a sudden worsening of chronic symptoms with a return to baseline symptoms after treatment. Although the diagnosis of sinusitis is clinical, adjunctive studies can provide invaluable information. Nasal endoscopy, using a lighted magnifying tube, can identify anatomic abnormalities and the presence of purulence not detectable with anterior rhinoscopy. Furthermore, endoscopic guided cultures have been shown to be as valuable as sinus puncture in identifying pathogenic organisms, allowing culture-directed antibiotic therapy. Endoscopic guided culture has the added advantage of allowing cultures to be taken from the drainage pathways of the ethmoid, sphenoid, and frontal sinuses. Although there is no longer any role for plain films, regular X-ray, in the diagnosis or management of sinusitis in adults, limited coronal computed tomography, CT, can be helpful in confirming the diagnosis of chronic rhinosinusitis. While CT scanning can aid diagnosis and management, its limitations must be recognized. CT changes suggestive of rhinosinusitis occur during and for up to 2 weeks following viral URI in the absence of bacterial or chronic rhinosinusitis, and the absence of chronic mucosal changes on CT scan does not exclude the diagnosis of sinusitis. After an episode of acute bacterial sinusitis, imaging abnormalities may persist in the absence of pathology for 6 weeks or more. Finally, areas of mucosal thickening suggestive of chronic sinusitis are present in a surprisingly large proportion of patients with no sinus complaints. Despite these limitations, CT scanning is invaluable in defining sinus anatomy, bony changes, retained secretions, and in identifying serious complications of sinusitis. In addition to the diagnostic workup directed at the paranasal sinuses, other underlying and associated disease processes require comprehensive evaluation. Patients with seasonal complaints or other stigmata of systemic allergies should undergo allergy testing. Pulmonary lung function testing is a critical part of the evaluation for sinus disease in patients with voice complaints and should be considered in many non-voice patients. The symptoms of vocal fatigue that occur due to the mucosal drying effects of chronic sinusitis are sometimes indistinguishable from symptoms secondary to low-grade exercise-induced asthma. Frequently, a previously undiagnosed pulmonary condition is identified during the workup for sinusitis, allowing the patient's vocal complaints to be addressed with specifically targeted treatments. Depending on the chronicity of symptoms and other pertinent medical history, testing for immunoglobulin subclass deficiencies, glucose, HIV, CF, and ciliary biopsies must be considered. The mainstay of treatment of acute sinusitis is oral antibiotics. Oral and topical decongestants also are prescribed often. When possible, endoscopic guided cultures of sinus purulence should be obtained and used to guide antibiotic coverage when culture and sensitivities are available. The choice of antibiotics should be governed by the severity of infection, chronicity of symptoms, and local microbial resistance profiles. Patients with chronic sinusitis frequently are infected by gram-negative and anaerobic organisms, and initial therapy should include agents effective against these organisms. Infection can spread from the sinuses to the orbit, meninges, and brain, threatening vision or life. These serious complications require hospitalization and intravenous broad-spectrum antibiotics. Emergent surgical intervention is required in some cases. Chronic sinusitis is primarily a medical, as opposed to surgical, disease. Treatment requires long courses of culture-directed antibiotics, topical and frequently oral steroids, and aggressive treatment of any underlying conditions. Antihistamines or desensitization regimens are indicated for patients with significant allergy symptoms, and environmental triggers must be avoided when possible. Tobacco smoke is a significant irritant and may not be avoidable by professional voice users, but smoking should be discouraged strongly, and exposure to secondhand smoke should be minimized. In patients in whom aggressive and comprehensive medical therapy fails to control symptoms adequately, functional endoscopic sinus surgery, FES, can be considered. This surgical technique is termed functional in that it is intended to improve the natural function of the paranasal sinuses. Older techniques relied upon gravity drainage of the operated sinuses and frequently involved complete removal of natural mucosa. Regenerated mucosa has significantly fewer cilia per square area, impairing the nasal mucosa's natural mucociliary clearance mechanisms. In addition, a series of elegant experiments has shown that cilia remain oriented towards the natural drainage pathway despite surgically created accessory ostia. This can create a particularly difficult problem called recirculation, when cilia move mucus out of the natural ostium and it falls back into the sinus via the accessory ostia. Functional endoscopic sinus surgery has as its goal the enlargement of the natural drainage pathways of the paranasal sinuses with preservation of natural mucosa. Although a majority of patients will experience symptom relief, chronic medication use is most often required to maintain the results. Patients with sinonasal polyposis often require multiple surgeries due to polyp recurrence, despite maximal medical therapy. Complications of sinus surgery are rare, but they can be very serious, including CSF leak, blindness, and major vascular injury. As sinus surgery changes the anatomy of the sinuses, a potential complication of sinus surgery is unwanted change in the resonance characteristics of the voice. Although many experts believe that the sinuses actually play only a minor role in voice resonance compared to the nasal passages, mouth, and pharynx, 2 small studies have documented both perceptual and acoustic changes in the speaking voices of patients following surgery. Although there are no reports in the literature of adverse effects of sinus surgery on the voices of professional voice users, it is prudent to discuss the possibility of unwanted changes with patients before surgery. Asthma and chronic sinusitis are frequent comorbidities. Although there remains some controversy in the literature, it seems that functional endoscopic sinus surgery improves asthma symptoms and pulmonary function tests and decreases medication use in a significant proportion of patients. As inhaled corticosteroids, the mainstay of asthma treatment, have rare but substantial vocal complications, reduction in medication use is a laudable goal, especially in professional voice users. Other obvious benefits of asthma symptom reduction are improved breath support and lung power, decreased oral corticosteroid use, and decreased incidence of acute asthma flares with fewer emergency room visits and hospitalizations. Sinusitis also directly affects the voice by altering the amount and consistency of mucus and causing nasal obstruction, loss of nasal resonance, and the debilitating effects of a chronic, generalized, potentially severe illness. Sinusitis is a common illness that can have detrimental effects in the professional voice user, not just singers and actors, but also teachers, clergy, salespeople, and others, including nasal obstruction with drawing of the mucus blanket, changes in nasal resonance, exacerbation of asthma symptoms, as well as the pain, fever, and generalized malaise that accompanies serious illness. Frequent exacerbations of sinusitis can interrupt work schedules, promote maladaptive voice habits, and lead to serious complications of sinusitis. Aggressive diagnostic workup and treatment of sinus disease can be critical in obtaining the best, most consistent treatment results. Like noses, sinuses can also be fractured. Usually this requires a great deal of force and happens at the same time as other facial fractures. Like infection, fractures may involve the maxillary, ethmoid, frontal, or sphenoid sinuses. Sinus fractures are associated commonly with fractures into the cranial vault and with CSF rhinorrhea. The clear, watery CSF discharge may go unrecognized initially because of bleeding associated with the fracture. However, it is usually apparent within a day or two. It is important not to ignore this sign and assume that it is simply a runny nose. Fractures in this region provide an easy path for bacteria in the sinuses to enter the head and cause serious infections such as meningitis and brain abscess. There have been substantial advances in the treatment of disorders of the nose and sinuses, and in taste and smell disorders. These advances have allowed us to treat many more patients effectively without surgery. When surgery is necessary, limited access technology has rendered sinonasal surgery much less traumatic and much more effective.